In this lecture, we will discuss left anterior fascicular block, including its pathophysiology, EKG features, potential causes, and clinical significance. If you recall, the normal electrical conduction of the heart starts at the sinus node or the SA node in the right atrium. Okay, so let's review our conduction system. Here we have our sinus node up here. This is our right atrium, our left atrium, right ventricle and left ventricle. So our sinus node up here in our right atrium near superior vena cava, which is this. So this is our SA node. Then we have our AV node here. Okay, and then after the AV node, we have our His bundle. Okay, then from our His bundle, we get the right and left bundle branches. This is on the right side, our right bundle branch, and then going towards the left side, we have our left bundle branch. The left bundle branch then subdivides into a anterior and posterior fascicle. Okay, and here's our left anterior fascicle, and this here would be our left posterior fascicle. Okay, now generally the left anterior fascicle is an organized thin bundle of fibers coming off the left bundle that gives rise to the Purkinje fibers, which then innervates the anterior and lateral walls of the left ventricle. Okay, so again, this is our left anterior fascicle, and it innervates the anterior and lateral walls of the left ventricle. On the other hand, while the left posterior fascicle originates from the left bundle branch, its fibers are not organized into a tight fascicle, but rather dispersed loosely and fanned out. The left posterior fascicle innervates the inferior and posterior walls of the left ventricle. Okay, so again, left anterior, we said is the innervates the anterior and lateral portions of the heart. Okay, the left posterior innervates here the inferior as well as the posterior walls of the left ventricle. Okay, so as you can see here, the left bundle branch subdivides into these two main fascicles, the left anterior fascicle and the left posterior fascicle. And the term fascicular block, or sometimes referred to as hemiblock, refers to an anatomical or functional dysfunction in one of these fascicles. In other words, a conduction block of the left anterior fascicle is referred to as a left anterior fascicular block, or sometimes referred to as a left anterior hemiblock, and a conduction block of the left posterior fascicle is referred to as a left posterior fascicular block, or sometimes a left posterior hemiblock. Hopefully that makes sense. And just in a quick clinical note here, because the left anterior fascicle is much thinner than the left posterior fascicle, it is at a greater risk of injury from ischemia. It also receives less arterial blood supply, which contributes to its greater vulnerability to damage. Okay, so these fascicular blocks that we're looking at here cause the ventricles to be innervated asynchronously, okay, or aberrantly. Therefore, the vectors produced by the left ventricle will be altered and will affect what we see on the EKG. Our focus in this lecture will be the left anterior fascicular block. Remember, the left anterior fascicle supplies the anterior and lateral walls of the left ventricle. So we said that left anterior fascicular block results from a dysfunction in the left anterior fascicle. So let's just clear up our heart here so we can see this more clearly. So now we're focusing on this block of that left anterior fascicle, and you can see that marked here. Okay, that's our left anterior fascicle that is blocked in that case, so the conduction cannot go past it. Now, because this fascicle is blocked, depolarization of the left ventricle has to progress from the interventricular septum, the inferior wall, and the posterior wall toward the anterior and lateral walls of the heart. Okay, this results in an unopposed vector that is directed superiorly and leftward. In addition, because the right bundle branch is not affected, the right ventricle will depolarize normally. Okay, so again, on the right side of the heart, okay, we have our right bundle branch, and our right ventricle will be fine. Okay, everything is able to get through to the right side. There's no issue there. Okay, and same thing's true with our left posterior fascicle, this one here. Okay, so the inferior and posterior areas of the wall are able to get innervated normally, so that's inferior and posterior, and same thing with our right side. Okay, and that's what that initial vector here shows. Okay, it's coming this way. That's where we have our initial vector going in that direction. And then we have to travel to our lateral and superior portions, our anterior portions, and that's why you have the second vector that's much stronger. Okay, and you'll have that slow cell-to-cell depolarization heading in that direction because that's where that area has been blocked by this at the left anterior fascicle. Okay. So because the vector is not directed in the normal inferior and leftward direction, but instead in that superior and leftward direction, this results in left axis deviation. The electrical axis of the ventricles will be found in the left quadrant of the hexaxial system, or in the frontal plane, specifically between -30 and -90 degrees. And often it's actually beyond -45 degrees. So again, that arrow, that second arrow, the second vector, let's just erase that here. The second vector here, number 2, okay, heading in this direction is going in the leftward and superior direction. So that's going to be in the left axis deviation quadrant, okay? So remember, normal axis lies between -30 and +105, or sometimes +110 degrees. That's normal axis. In this case, because we're directed leftward and superiorly, we're going to be in this region. That's where that second vector is heading, okay? And that's the leftward axis deviation region, okay? So normally it will be between -30 and -90, but something that is, actually something we see is some will consider once we hit that -45 degrees, this region here and beyond is actually what really defines left anterior fascicular block. Okay, so this is the first EKG criteria we should be aware of diagnosing left anterior hemiblock. Okay, and left axis deviation is actually, like you said, considered by some cardiologists as the hallmarks in making the diagnosis. Okay, in other words, if the axis is beyond -45 degrees, you're likely dealing with left anterior fascicular block. If the axis is between -30 and -45 degrees, which is this region here, okay, it's generally considered probable left anterior fascicular block, okay? So remember, a simple way of making the diagnosis of left anterior fascicular block is positive complexes in lead 1, negative complexes in lead 2 and AVF. It's really that simple, and you don't really have to make it any harder than it has to be, okay? So again, why is it positive? So remember, let's just erase this here. Okay, so again, we're looking for something between -45 degrees and -90 for our true left anterior fascicular block, okay? And what we have here is positive in lead 1, meaning if we have a positive upright vector in lead 1, which is here, notice it's upright, going towards lead 1, which is here, and then we're going to look for a negative in AVF. This is AVF. Notice we have the negative in AVF, so this is the positive end of AVF, so we'd be heading this way, okay? And then we want to look at lead 2, which again, perpendicular to lead 2 would put us right here, so we want lead 2 to be on this side, which means it has to be negative, okay? So negative on lead 2 puts us in this region here, okay, the true left axis deviation, okay? So really look for upright in lead 1 and negative in leads 2 and AVF, okay? And that can pretty much give you the diagnosis, okay? So let's look at some of the other EKG features. So we can see QR complexes in the lateral leads, 1 in AVL, or simply a large monophasic R wave in lead 1. Whereas in the inferior leads, we'll see, which are 2, 3, and AVF, we could see these RS complexes. And notice that the QR complexes in the lateral leads, 1 in AVL, and the RS complexes in the inferior leads have small initial Q and R waves, okay? They result from unopposed interventricular depolarization vector that we have here. So let's just see where these are coming about. So first off, now we're saying that we're looking at, aside from the left axis deviation, we're looking at the lateral leads, which are these ones here, okay? And then we have the inferior leads, 2, 3, and AVF. And in the lateral leads, which would be placed here, here's 1, and we'll also put AVL there. AVL is more of a high lateral lead. And then we have 2, 3, and AVS are inferior leads. So here's like 2, this would be 3, and this would be AVF, okay? And what we're saying here is that in the inferior leads, 2, 3, and AVF, we can see these RS complexes with a small r. This is the initial small r wave, and then a large S deflection. And then in the lateral leads, we'll see these QR complexes, okay, in which we have a small q and a large r. Now sometimes we said we can see these monophasic R waves in lead 1, in which there's no initial small Q wave. Okay, so the small R and the small Q wave come from that initial interventricular depolarization vector that's unopposed, okay? All right, so notice that the small R wave in the inferior leads is positive because notice the vector is heading towards them, okay? And it's heading away from the lateral leads, and that's why we see this a small Q wave in those leads, okay? This initial vector that's depolarizing the interventricular septum is heading away, and that's why we see small Q waves in 1 and AVL, okay? Now the large S wave and the large R wave come from the second vector, the strong second impulse that's heading towards now A1 and AVL, okay? And that's why we see this upright R wave in 1 and AVL, the lateral leads, and we'll see a negative deflection in the S wave as that vector heads away from these inferior leads, okay? So again, in the inferior leads, these RS complexes, and in the lateral leads, the QR complexes, okay? And you can see them here. Okay, those in blue here, 1 and AVL are lateral leads. Notice we have here the small Q in the R wave, and the same thing here. All right. Sometimes I put those there because they're sometimes easy to see, and you can see where everything is on the EKG. And notice that we're dealing with the limb leads. We're not really even touching the precordial leads on V1 through V6. Okay, so I didn't really put those here. Now the inferior leads, 2, 3, and AVF, we said we can see these small R waves in the RS complexes throughout. Okay, so hopefully that will help you when looking at these. Okay, just a few other points. The QRS interval is generally normal, but may be slightly prolonged by 10 to 40 milliseconds from that conduction delay of the left anterior fascicle. The R wave peak time, which we call the intrinsicoid deflection, may also be increased in lead AVL, okay, that lateral lead. The QRS voltage in the limb leads may meet the left ventricular voltage criteria, but you generally won't see the associated strain pattern. Remember, we want the voltage and non-voltage criteria for making that left ventricular hypertrophy diagnosis. And just a few last notes on the EKG. These findings may mimic an anteroseptal MI or mask an inferior MI, okay? So make sure to be aware of that. Additionally, T-wave inversion in leads 1 and AVL, the lateral leads, may occur, which may mimic actually post-ischemic T-wave. Now mark these points, okay, and they're right here. So I want you to mark them, and after we discuss infarctions, I want you to come back, and I think they'll make more sense, okay? So let's just finish with some potential causes and clinical significance. So it's possible to see left anterior fascicular block in some healthy individuals, but oftentimes we will see it in those with significant heart disease. Some causes include hypertension, left ventricular hypertrophy, coronary artery disease, myocardial infarctions, dilated or hypertrophic cardiomyopathy, degenerative disease, okay, of that left anterior fascicle, myocarditis, amyloidosis, as well as hyperkalemia. Now, clinically speaking, left anterior fascicular block is more common than left posterior fascicular block, and that's due to the left anterior fascicle's smaller arterial blood supply, as well as we said it has that thin fiber composition. Now, left anterior fascicular block is often benign if it's isolated, although it's important to be aware that some cases may progress to bifascicular block, that is involving the right bundle branch block, okay, the right bundle branch on the right side of the heart, and even complete heart block, in which you have all the fascicles and the bundle branches blocked, all right? So let's quickly review what we discussed before we end here. So left anterior fascicular block, or left anterior hemiblock, is an anatomical or functional dysfunction at the left anterior fascicle, okay? And because of that, the left ventricle is being depolarized by this left posterior fascicle initially. So remember, left anterior fascicle, it's thin, organized fibers innervating the anterolateral, the anterior and lateral aspects of the left ventricle. And then we talked about these vectors, that initial weaker vector that's heading, this number 1, heading inferiorly rightward, okay? And because of that, we get those small R and Q waves in our lateral and inferior leads. And then that stronger vector that's going leftward and superior directed, that's where we see those deep S waves and the large R waves in our leads, okay? We said the inferior leads, we see these RS complexes, and the lateral leads, the QR complexes, okay? Now the EKG criteria, remember, the main one I want you to know is this left axis deviation, and when it's beyond that negative 45 degrees, okay? And all you have to do is simply look at the EKG and notice a positive upright complex in 1, negative in 2, and negative in AVF, okay? That will put you in that region. If it's between negative 30 and negative 45, then that's considered probable left anterior fascicular block, okay? Now the other criteria we said in the lateral leads, 1 and AVL, look for those RS complexes, okay? Or the QR complexes, and you can possibly see a monophasic R wave in lead 1. And then the inferior leads, those are where we want to look for those RS complexes, okay? Now, QRS interval will normally be within normal limits, less than 110 milliseconds. It could be slightly prolonged because of this delay in conduction. All right. There's a number of other features here with that increase in the intrinsicoid deflection period, as well as an increase in the QRS voltage in the limb leads. So sometimes you may see the left ventricular hypertrophy voltage criteria in these leads be met, although there will be no strain pattern present as well. Okay, and then I said to mark this and come back to some of those mimickers of MIs. Okay, when we talk about ischemia and infarction in upcoming lectures, there's a number of causes, and the clinical significance is one thing I want you to know, that this is more common than left posterior fascicular block, and that's because of those thin bundle of fibers that are, that composition of this left anterior fascicle and the smaller arterial blood supply. Okay, now generally if this is isolated, it tends to be benign. Okay, and then we said in some cases it can progress to bifascicular or even complete heart block. Well, that's the end of this lecture. We discussed left anterior fascicular block, including its pathophysiology, EKG features, potential causes, and clinical significance. I hope you learned something.